Hello everyone, welcome to Unacademy. Let's crack NEET PG. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and a educator in Unacademy. I have an experience of teaching undergraduate and postgraduate medical students. I have done my MBBS and MD from Rajiv Gandhi University of Health Sciences. Today we'll be discussing about immunodeficiency and various types of immunodeficiencies. Also, this is quite an important topic because there are a lot of syndromes and a lot of microbiology aspects come into this, and so this is a very important topic. So kindly give a watch of this class. Before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform, and there are a lot of benefits you can avail. First of all, the daily live classes. There are regular classes happening every day, and you can watch these live classes every day, and you can chat with your educator, ask your questions, and that will be answered immediately in the live chat box. Also, whenever you're preparing for an for an entrance exam, you need to have a structured course. That means you have to plan it well. Okay, so that you have enough time to revise again. Right, so here in Unacademy, all these courses are structured in line with your exam syllabus. That is going to be of a huge for your preparation. Also, whenever you're preparing for your entrance exam, you need to know what is your strong area, weak area. You need to analyze yourself so that you can concentrate better on your weak subjects, right? So in Unacademy, we have regular live tests, quizzes, mock tests happening so that you can analyze yourself and concentrate better on the weaker subjects. Also, coming to the unlimited access. So once you subscribe to the subscription, you have unlimited access to all the classes. Okay, so if you have missed a live class, you can go back and watch the recorded class again and again. So all this in the comfort of your home, in the comfort of your own device. So I would highly recommend this platform for your preparation for your entrance exam, for your NEET PG. Also, using this platform in the beginning part of your preparation will do a huge. Okay, so coming to this next slide, this is the here these are our top educators, and they have regular classes happening in this platform. All the subjects required for your NEET PG preparation are taught in this platform. Okay, and these are the ongoing courses in our platform right now. Okay, coming to the NEET PG subscription, as you can see, the NEET PG subscription package varies from 1 month to 2 years. I would recommend the 12-month or the 24-month subscription, as the NEET preparation is a 1 year long preparation, and taking a 12-month or a 24-month subscription package will be more reasonable. Okay, a 12-month subscription is comes to up to 25,000, but if you use my code Shilpa10, okay, you will get a 10% discount and it will come up to 22,500. And a 2 year subscription which comes up to 30,000, and using my code Shilpa10, you get a 10% discount and it will come up to 27,000. So the prices are very reasonable compared to other platforms, and yes, highly recommended to use this platform. So now coming to today's topic, immunodeficiency. Before knowing about immunodeficiency, let us know the basics. So first of all, immunity. Okay, so our immunity is made by is composed of two types of immune system. One is the innate immune system. Okay, second is the adaptive immune system. Okay, the innate immune system is a primitive immune system, and this has no memory. Okay, while the adaptive immune system is a highly evolved immune system. Okay, and has memory. So when you get reinfected by the same organism or the pathogen, your body also already has the memory of that pathogen, and then that can be eliminated from the system. So that is why memory is very important. Okay, so now coming to the innate immune system. So the innate immune system is formed by, one is the complement system. Okay, and next another is the cellular part of the cellular part of the innate system is formed by the polymorphonuclear cells. Okay, polymorphonuclear leukocytes, natural killer cells, and macrophages. Okay, so now coming to the complement system. So coming to the complement system, you need to know the complement system has three pathways, right? One is the classical pathway, the lectin pathway, and the alternate pathway. Okay. Okay. So now, okay. So all these, so in the complement system, yeah. Hello, Gora. Yeah. So in the complement system, so what we need to know is, uh, if this is the classical pathway, so classical pathway is triggered by antibody complexes, antibody antigen complexes. Antigen antibody complexes. Okay, so that is, there will be C1q is a part of the classical pathway. Then there is C4 and C2. Okay, next coming to the lectin pathway. So lectin pathway is activated by binding of the binding of mannose binding lectin to the mannose residues on the pathogen. Okay, I'll tell you very clearly, you might don't get confused. Next is the alternate pathway. Okay, so this is again based on the characteristics of the organism. Charge characteristics. Okay, so the classical pathway is triggered by the antigen antibody complexes, while the lectin pathway and the alternate pathway are by the pathogens. Okay, so in the lectin pathway, there is mannose binding lectin, and then there is C4 C2, while in the alternate pathway there is factor B, factor D, and properdin. Okay, all this go to the activation of, all this, okay, leads to the activation of C3. Okay, C3, and this C3 further lyses and causes C5, C6, C7, C8, C9. So now you have to remember what are the complements in the early part of the system, complement system. So all these C1, C4, C2, C3 are the complements of the early part of the complement system, while C5, C6, C7 are from the later component. Okay, so a deficiency in the early components causes different presentation, while the later components cause a different presentation. So that is why you need to know. Okay, now coming to the, okay, did you all get to know? Is there any doubt here? Okay, so let's move on to the adaptive immune system. So the adaptive immune system okay, is formed by the T cells, B cells, and the NK cells. Okay, so now the T cells have the T cell receptors. Okay, so this helps to bind to the MHC molecules. MHC molecules are the major histocompatibility molecules. Okay, so now in the T cells, it is categorized into T helper cells and T cytotoxic cells. Okay, the T helper cells are further divided into T helper cell 1, T helper cell 2, and T helper cell 17. Okay, and the cytotoxic cells, okay, are they help in eliminating intracellular pathogens. So while what does these helper cells 1, 2 and 17 do? So T helper cell 1, okay, they support inflammation and activates T cytotoxic cells. Okay, yeah. What does T helper cell 2 do? Okay, it induces antibody mediated immunity. Okay, while what does T helper cell 17 do? 17, it contributes to the host defense against the extracellular bacteria and fungi. Okay. So this is the adaptive and the innate immune system. So now coming to the immunodeficiency. So immunodeficiency is basically divided into primary immunodeficiency and secondary immunodeficiency. So secondary immunodeficiency is generally because of certain infections, okay, certain drugs. So the most common cause of secondary immunodeficiency is HIV. Okay, but when a child comes, because diagnosing primary immunodeficiency is not very easy. So when a child comes with primary immunodeficiency, how do you suspect this child could have primary immunodeficiency? So you need to know these 10 warning signs. Okay, out of which 2 or more than 2 should be present. So 1, if there is 4 or more than 4 new infection in a year. Okay, secondly, if there is 2 or more serious sinus infections in a year, if there is 2 or more episodes of pneumonia in a year, fourthly, if there was 2 or more months of antibiotics without any effect, fifthly, if there is failure of an infant to gain weight or grow normally, gain weight. Okay, that means if there is failure to thrive. Okay, sixth, if there is recurrent deep skin infections or organ abscesses. Seventhly, so if there is persistent oral thrush, that is candidiasis, fungal infection, oral thrush. Eighth, if there is need of IV antibiotics. To clear an infection. Ninth, if there is more than 2 deep-seated infections like meningitis, cellulitis, okay, deep-seated infections. And 10th, family history of immunodeficiency. Okay, so all these gives you a you should, if there is two or more of these warning signs, then that should give you a clue that the child has a primary immunodeficiency. Now, so coming to the classification of primary and secondary immunodeficiency. So there could be defect in anywhere. So one is there could be any antibody deficiencies. Okay, so antibodies are not produced, so that could cause immunodeficiency. Severe combined immunodeficiency, that means the B's, the humoral and the cellular immunity both are affected. Okay, other cellular immunodeficiencies. Okay, then defects in the phagocyte function. Okay, if the phagocyte is affected, the function of the phagocyte is affected. Immunodeficiencies associated with lymphoproliferative disorders. Complement deficiencies. Immunodeficiencies associated with or secondary to the to other diseases, other immunodeficiency. Okay, over here an example is hyper IgE syndrome. Okay, so remember, so that is why I've spoken about the innate and the adaptive immune system. So basically, see, the antibody deficiencies, if there is antibody deficiencies, your immune system won't work. If both the humoral and the cellular immunity is affected, then again your immunity won't work and there could be immunodeficiency. If the phagocytes do not work well, then there could be immunodeficiency, right? Complements do not work, there could be immunodeficiency. So that is why knowing the immune system is required to understand immunodeficiency better. Okay, so now coming to X-linked A gamma globulinemia. Okay, so this is because of an antibody deficiency. Okay, so A gamma globulinemia means it indicates deficiency. Okay, so now this X-linked A gamma globulinemia is also called as Bruton A gamma globulinemia. Okay, so this is a X-linked recessive disorder. Okay, so this is a X-linked recessive disorder. Now what is the mutation? The mutation is in the gene which codes for tyrosine kinase. Tyrosine kinase. So this is also called as Bruton tyrosine kinase. So there might be a question, where is Bruton tyrosine kinase deficiency present, or where is in which condition there will be Bruton tyrosine kinase gene mutated. So they might not give you as Bruton A gamma globulinemia, they might give you X-linked gamma globulinemia, and they could give autosomal recessive A gamma globulinemia. So you shouldn't get confused. The answer is X-linked A gamma globulinemia. So what happens in these children? So in these children there is low levels of IgG, IgA and IgE. Okay, but there is raised IgM. Okay? And these children, what happens is these children are what get they have high risk of getting infected with pneumocystis jirovecii. Okay, and they are associated with many autoimmune disorders. Okay, another thing is these children, their tonsils and the lymph nodes are atrophied. Fine, so this is more of a humoral immunodeficiency. Okay, so when you get a flow cytometry done, that time there will be absence of B cells, in the peripheral blood. Okay. Next, coming to hyper IgM syndrome. So hyper IgM syndromes, over here there is raised IgM, while other immunoglobulins are decreased. Okay. Now these children have a high susceptibility to pneumocystis jirovecii uh, infection. So now these children become symptomatic at by at 1 and 2 years of life. The first 2 years of life, they get symptomatic. So what happens? They have recurrent pyogenic infections. So recurrent pyogenic infections happen how? So they have a recurrent otitis media, so they have recurrent pneumonia, okay, they have recurrent tonsillitis. So these are the recurrent pyogenic infections. Okay. And then when you get a blood test done, there is profound neutropenia. Okay, so there is profound neutropenia, and the treatment for IgM is there. It should be a HLA identical hematopoietic stem cell transplant. Okay, HLA, this is the cure for it. Okay. And if there is when there is neutropenia, you can when there is neutropenia, a trial of granulocyte colony stimulating factor could be tried. Factor could be tried. Okay. Next, so next, coming to severe combined immunodeficiency. So what is severe combined immunodeficiency? So here both the humoral and the cellular immunity is affected. Both cellular and humoral immunity is affected. Okay. So in these children there is severe infections. Severe infections. Again over here there is the tonsillar and the lymph nodes. Tonsillar and the lymph nodes are atrophied. They're not palpable. Okay. And if these children are left untreated, they succumb in the first few months of life. Okay. And these children have lymphopenia. Okay. Lymphopenia. So what did I say? Where was neutropenia? Neutropenia was in the hyper IgM syndrome. Here there is lymphopenia. Okay. So and the severe combined immunodeficiencies, there are various severe combined immunodeficiencies. The most common out of that is X-linked severe combined immunodeficiency. Over here there is mutation in the common gamma chain. Okay, there is mutation in the common gamma chain of interleukin 2. Okay. So there is a severe combined immunodeficiency, another form where the purine nucleoside deaminase, sorry, purine nucleoside uh, phosphorylase deficiency. Okay, so this is a milder form of severe combined immunodeficiency, and it happens in the later part of childhood. Okay, so now coming to other cellular immunodeficiencies. First example for cellular immunodeficiency is Wiskott-Aldrich syndrome. So in Wiskott-Aldrich syndrome, do you all know what is the inheritance? Anyone knows what is the inheritance? Okay, so the Wiskott-Aldrich syndrome, the inheritance is X-linked recessive. Okay, so there is a mutation in the chromosome 11. Okay, so and as a result, the Wiskott-Aldrich protein is this chromosome encodes for the viscod Aldrich protein, which is defective. Okay, so here there could be history of severe bleeding. Okay, eczema, eczema, and then there is poor growth. Okay, so some children might come with history of severe bleeding during circumcision. Okay, eczema might be confused for atopic dermatitis. Okay, but then the eczema will be very severe in these children, and these children have recurrent infections. Okay, another thing which you have to keep in mind is these children have thrombocytopenia. Okay, and they are highly susceptible to polysaccharide antigens. Okay, polysaccharide antigens, and as a result they are highly susceptible to all these pneumococci, meningococci, and Haemophilus influenza, and there is recurrent pneumonia, meningitis in these. Okay, these children can present with as viscod Aldrich spectrum syndrome spectrum. So either it could be a mild disease to severe bleeds. Okay, so these children have a higher risk of malignancies. Okay, especially the lymphoreticular malignancy. Okay, now another thing is when you check for the immunoglobulins, there is a severe deficiency of immunoglobulin M. Okay, and there is a increase in immunoglobulin A, immunoglobulin E, and the immunoglobulin G might be normal. So just remember this. You want to remember that. So immunoglobulin M is severely reduced. Okay, severe deficiency. Okay, and these children, the cause of death in viscod Aldrich syndrome is because of infection, bleeding, and because of Epstein-Barr virus associated malignancy. Okay, so these children might need monthly infusions of IVIG. Okay, infusions of IVIG. Okay, so this is about Biscott-Aldrich syndrome. So you need to know this is an X-linked recessive disorder, and the chromosome involved is chromosome 11, and these children present with either bleeding, eczema, poor growth. Eczema and bleeding is more common, and when you get a blood test, then there is thrombocytopenia. Also, when you check the immunoglobulin levels, there is a severely reduced IgM. Okay. Now coming to ataxia telangiectasia. So what is ataxia telangiectasia? Uh, this is a autosomal recessive disorder. Okay, so you can see there is two parts. There is ataxia and telangiectasia. So in ataxia, there is progressive cerebellar ataxia. Okay, and the telangiectasia is oculocutaneous telangiectasia. So this ocular first is seen in the bulbar part of the in the bulbar conjunctiva. Okay, first is seen in the bulbar conjunctiva. Okay, it is seen between the age of 3 to 6 years. While the ataxia is noted when the child starts to walk. Okay, so this ataxia progresses and eventually the child will be bound to a wheelchair. Okay, that is between the age of 10 to 12 years. Okay, and the chromosome which is affected here is chromosome 11. Okay, 11q. So, but the immunodeficiency when compared to Viscott-Aldrich syndrome, it is lesser, the immunodeficiency compared to lesser. And these children, one of the presentation is these children come with recurrent sinopulmonary infections, recurrent sinopulmonary infection. And as a result, these children will be thin built because of this infection happening. They do not have a chance to grow. Okay, and these children have high incidence of malignancy. Okay, malignancies. So again over here, it's most commonly it is reticular, but adenocarcinoma is also common in these children. Okay, and when you get the immunoglobulin levels done, there is absent to very low levels of IgA. Okay, remember A for IgA, that is very low. Fine. So this is about ataxia telangiectasia. Next, coming to Digeorge anomaly. So Digeorge anomaly you should be knowing. It is because of the defect in the during the embryogenesis of the fourth and the third and the fourth pharyngeal pouches. So this is because of the defect during embryogenesis. Embryogenesis. So that time what happens? It affects the third and the fourth pharyngeal pouches. Pharyngeal pouch. Okay, so that is why there is thymic hypoplasia. There will be absent thymus. Okay, in these children there is absent thymus, and they have a peculiar facies. Okay, dysmorphic facies. So how is it? So there is hypertelorism, anti-mongoloid slant, low set ears. There is micrognathia, short philtrum, and bifid uvula. So remember this. Bifid uvula. Okay, bifid uvula hyperthyroidism, but remember this. Okay. Next, these children have absent thymus. There can because there is hypocalcemic tetany. Then there is aortic arch abnormalities. Okay, the aortic arch is abnormal in these. Okay, so this you need to remember. So in a Digeorge anomaly, there is defect in the embryogenesis in the third and the fourth pharyngeal pouch, and uh, pouch, and as a result there is absent thymus, and they have a peculiar facies, that is they have a hypertelorism, anti-mongoloid slant, and low set ears, micrognathia, and short philtrum, and a bifid uvula. And also these children present with hypocalcemic tetany, and on examination they can have a abnormal aortic arch. Okay, so these children have a T cell defect. Okay, and these children are very prone to severe infections, because there is a T cell defect. Their body is not able to contain the infection. Okay, and in severe diseases, a thymus transplant or a hematopoietic stem cell transplant is needed. Okay, so this is about Digeorge anomaly, and this is in the cellular immunodeficiencies. Now coming to the defects in the phagocyte function. So in the phagocyte function, there are children present with chronic granulomatous disease. So in chronic granulomatous disease, there are various diseases involved. So how do these children present with? Okay, these disorders have reduced NADPH oxidase, DPH oxidase. Okay, so this leads to impaired generation of superoxide radical. Okay, so this can be both X-linked, okay, or autosomal recessive. So X-linked in 50% of the chances of it being is X-linked. So there the gene which is mutated is uh, GP 91 Fox. While in the autosomal recessive, the gene which is mutated that encodes to GP 47 Fox, GP 67 Fox, GP 22 Fox. Okay, so these children have are highly susceptible for recurrent serious infections. So all the children with immunodeficiency, they have recurrent serious infections. Okay. Okay. And these infections are mostly caused by the catalase positive bacteria. So catalase positive bacteria, that is the Staphylococcus aureus and Serratia in the bacteria, and fungi like Aspergillus. Okay, so these children have persistent pneumonia, they have prominent lymphadenitis, multiple liver abscesses, osteomyelitis of the small bones in the hands and the feet. So the diagnosis is done by nitroblue tetrazolium dye reduction test. Nitroblue tetrazolium dye reduction test. Okay, and this is confirmed by flow cytometry. Okay, dihydrorhodamine assay is done by flow cytometry. Dihydrorhodamine. Fine. So this is how these children are managed, and the treatment again is hematopoietic stem cell transplant, and these children get have to be treated with trimethoprim sulfamethoxazole because these children have recurrent serious infection. So most of the children again have treatment with trimethoprim. So now coming to leukocyte adhesion defect. So this is another important thing you need to remember. In leukocyte adhesion defect, there are three types: leukocyte adhesion LAD 1, 2, and 3. Okay, this is a rare autosomal recessive disorder. Okay, so the chromosome which is affected is the chromosome 21. So these children present with recurrent fevers, high grade fever, and they have initially they are born normally, but then eventually they have what is it, growth retardation. So these children, when you get a blood test done, there is neutrophilia. But though there is neutrophilia, these neutrophils have have defect in addition. They have defect in adhesion, motility, and the ability to phagocyte. So all this is affected. Okay, and one more thing you need to remember in a leukocyte adhesion defect is there is history of delayed fall of umbilicus. So this history is very important. So you might get a case scenario where the child a child was born with which was appropriate for age. There was no perinatal birth asphyxia, but there was history of delayed fall of umbilicus, and now this child comes with recurrent what is it, recurrent infections. So what could your diagnosis be? So that time this is very important to kept in mind. So the answer will be leukocyte adhesion defect. Okay, so delayed fall of umbilicus is very characteristic of leukocyte adhesion defect. Okay, so this you need to keep in mind. And the treatment is again early allogenic, yeah, hematopoietic stem cell transplant. Okay, so now coming to the autoimmune lymphoproliferative disorders. So the autoimmune lymphoproliferative disorders are basically when there is a Fas ligand is defective. Okay, so these children present with so this is lymphoproliferative. So there is lymphadenitis, okay, lymphadenopathy, hypersplenism. Okay, and these children might have hepatomegaly also. Okay, so this is how they present, and again there is growth failure, repeated infections. Okay, so sometimes these children might need a splenectomy. Okay, and the blood count shows cytopenias. Okay, so this is how a autoimmune lymphoproliferative syndrome presents as. Now coming to complement deficiency. So now I have told you what are the early components of the complement system. So what did I say? C1, C2, C3, C4. So these are in the early component. So any deficiency in the early component of complement system, these children are prone to recurrent bacterial infection. And children who are deficient of the later components C5 to C9. So these have more predilection to Neisseria infections. Okay. Okay. And SLE occurs. SLE occurs in patients who in those who have C2 or C4 or C1q deficiency. Okay, so this you need to remember. SLE it happens in C2, C4 or C1q. And another important thing, Neisseria infection happens in deficiency of C5, C6, C7, C8, C9 complement deficiency. Okay, so there is another thing which you need to remember is that is C1 esterase inhibitor. So C1 esterase inhibitor, if that is deficient, that can lead to a hereditary angioneuritic edema. Hereditary angioneurotic edema. Okay, so these children will present with recurrent swellings in the body, itching. They might have life-threatening swellings. They might have severe, respiratory distress when such things happen. So you should keep this in mind. So when there is C1 esterase inhibitor deficiency, so these children might present with hereditary angioneurotic edema. Okay. So now coming to there's a classification for immunodeficiency associated with the secondary to other disease. So remember, if there is any chromosomal instability or defective repair, it could be because of Bloom syndrome, Fanconi anemia, Seckel syndrome, xeroderma pigmentosa. So you don't need to remember anything. I mean everything. So basically, you have to know these names. So you have to know these conditions present with immunodeficiency. Okay, you don't have to remember these headings perfectly, because more you remember like this, you will try to confuse. So just remember, so Bloom syndrome can present with immunodeficiency, Fanconi anemia can present with immunodeficiency, Seckel syndrome, xeroderma pigmentosa, Down syndrome, Turner syndrome. Okay, short limb skeletal dysplasia, immunodeficiency with absenteeism, Dubovich syndrome, progeria, partial albinism, dyskeratosis congenita, okay, acrodermatitis enteropathica, transcobalamin 2 deficiency, methylmalonic acidemia, glycogen storage disorder type 1B, Shediac-Higashi syndrome, Shediac-Higashi syndrome. So Shediac-Higashi syndrome, what happens? Here the neutrophils are there is defect in the degranulation of the neutrophil. Okay. So hypercatabolism of immunoglobulin. Okay, so these you need to remember. Also, some of the very important cause of secondary immunodeficiency is infections. Okay, so HIV is the very common condition for secondary immunodeficiency. Nephrotic syndrome. Okay, nephrotic syndrome, severe malnutrition. Okay, severe burns, any chronic infection, chronic severe infection. So all these can lead to secondary immunodeficiency. Now, one of the immunodeficiency which doesn't come under any of these, we need to remember is the hyper IgE syndrome. So the hyper IgE syndrome, what happens is there is a mutation in the STAT3 gene. Okay, so this leads to recurrent cold abscess. Okay, staphylococcal abscesses. There could be pneumonia with pneumococci. Okay, retained primary dentition, and there is elevated IgE levels. Okay, and this is the autosomal dominant disease. You need to remember this. That is it. So main thing for this over here in hyper IgE syndrome is a STAT3 gene mutation. It is an autosomal dominant disease. There is highly elevated IgE levels, and these children present with recurrent cold staphylococcal abscesses. There could be pneumonia with pneumatoceles. Okay, and retained primary dentition. So this is what you need to remember. So so we'll have a fast brush up of everything. So as I've told you, we have the immune system is divided into innate immune system and the adaptive immune system. The innate immune system is primitive and there is no memory. So in the innate immune system, um, you have the complement system and the polymorphonuclear cells, macrophages, and the NK cells. Okay, while in the adaptive immune system, there is T cells, B cells. Okay, so in the T cells, there is T helper cells and the T cytotoxic cells, right? So in the complement system, I've told you this. So in the complement system, the pathway has three parts. One is the classical pathway, okay, which is triggered by the antigen antibody complex. Okay, then there's the lectin pathway. So that is triggered by the binding of mannose binding lectin to the mannose residue of the pathogen. Okay, so over here C4 C2 is included, while the alternate pathway it's triggered by charge characteristic like factor B, factor D, properdin. Okay, so these all depend on the pathogen. So lectin pathway and the alternate pathway depends on the pathogen, while the classical pathway depends on the antigen antibody complexes. So over here, as you can see, C1, C2, C4, C3 are in the early, they are the early components of the complement system, while C5, C6, C7, C8, C9 are the later components. Okay, so this will give you an idea of what kind of infections happen when the early component of the complement system are deficient, and what happens when the later component of the complement system are deficient. So adaptive immune system, I have told you. Okay, so now coming to the immunodeficiency. So if whenever immunodeficiency is divided into primary and secondary, so secondary is generally when there is a long-standing infection, or if there is a chronic illness, if there is certain drugs can cause like cyclophosphamide, glucocorticoids. So these cause secondary immunodeficiency. There is a cause. Okay, so if that is treated, then the immunodeficiency will be managed. But there are certain conditions which are because of the uh, defect in the immune system. So that is called primary immunodeficiency. So when a child comes to you, so how do you know this child should be uh, investigated for primary immunodeficiency? So you need to know 10 warning signs. So presence of two or uh, more than that, two or more criteria will give you a what is it? Will help you in diagnosing primary immunodeficiency, or even further investigate a child with immunodeficiency. So firstly, if the child has 4 or more new infection in a year, or 2 or more serious infection in a year, 2 or more pneumonias in a year, 2 or more months of antibiotics without any effect, failure to gain weight, recurrent deep skin infections or organ abscesses, persistent oral thrush, need of IV antibiotics. So oral antibiotics doesn't work. Need of IV antibiotics to manage the infection. More than two deep-seated infection like meningitis, cellulitis, and family history of immunodeficiency. So 2 or more of this is present, then it gives us a high chance to think it could be a primary immunodeficiency. So this primary and secondary immunodeficiencies are further classified based on what kind of deficiency it could be, or where the defect is. So if there is antibody deficiency, or if there is combined immunodeficiencies, both being humoral and cellular immunity, or only cellular immunodeficiencies, if there is phagocyte function is defective, if there is any lymphoproliferative disorders, these might have high levels of T cells and B cells. So again, that also causes immunodeficiency. Complement deficiencies. Immunodeficiency associated with secondary to other diseases. Other immunodeficiencies like hyper IgE syndrome. So now I've told you about antibody deficiency. So one is X-linked A gamma globulinemia. Over here, the B cells are absent. Okay, and these children have recurrent infections, and the mutation is in the gene tyrosine kinase, and it is called as Bruton tyrosine kinase. X-linked A gamma globulinemia is also called as Bruton A gamma globulinemia. And these children have tonsils and lymph nodes are atrophied, and flow cytometry shows absence of B cells in the peripheral. So this is basically B cells are absent, okay, in X-linked. So remember that in X-linked A gamma globulinemia, it is X-linked recessive. It is also called as Bruton A gamma globulinemia. The mutation is in the gene tyrosine kinase, also known as a Bruton tyrosine kinase. And here the tonsils and the lymph nodes are atrophied, and and when you test these children, there is absence of B cells in the peripheral blood. Okay, so this much you need to know for X-linked A gamma globulinemia. Hyper IgM syndrome. So these children have high susceptibility to have pneumocystis cerevisiae infection. They have profound neutropenia. Okay, they have profound neutropenia, and they have recurrent pyogenic infections. These children have raised IgM levels, and they have decreased IgG, IgA, and IgE. Okay, so remember this hyper IgM. So no one will ask you this, but they might ask you a condition where there is raised raised susceptibility to a child for cerevisiae and recurrent infection, and there is profound neutropenia, and they might give a this thing of IgM with decreased other values. So it might confuse you, but keep in mind it is hyper IgM syndrome. So if there is severe combined immunodeficiency, so here both cellular and humoral immunity is affected. So here children have severe infections. Also their tonsils and lymph nodes are atrophied. But the feature to differentiate is these children have severe lymphopenia. Okay. So there are various severe combined immunodeficiencies. The most common is the X-linked severe combined immunodeficiencies. Over here there is mutation in the common gamma chain of interleukin 2. Okay, so then another mild form of severe combined immunodeficiency is purine nucleoside phosphorylase deficiency. This affects in the older children. Okay, so now coming to other cellular immunodeficiencies. So firstly, Wiskott-Aldrich syndrome. It is a X-linked recessive disorder. The chromosome which is affected is chromosome 11. There is history of bleeding, eczema, and growth. So in these children, there is markedly reduced IgM. Okay. Also, when you get a blood test, then there is thrombocytopenia. Okay. So keep this in mind. So there is very high deficiency of IgM. Okay, and these children are present with bleeding, eczema, and poor growth. Okay, so this is what you need to know. Okay, coming to ataxia telangiectasia. So ataxia telangiectasia means is a autosomal recessive disorder, and the chromosome which is affected is chromosome 11, and these children have present with progressive cerebellar ataxia. So only when they start to walk, the ataxia gets noticed, and it is so much progressive that by the age of 10 to 12 years they are bound to a wheelchair. Okay, when it coming to the telangiectasia part, there is oculocutaneous telangiectasia, and it is first seen in the bulbar conjunctiva at 3 to 6 years. Okay, and these children have high high risk of developing malignancy, especially the lymphoreticular malignancy and adenocarcinoma. Okay, when you get the immunoglobulins tested, these children have decreased to absent to decreased levels of IgA. So remember, for ataxia telangiectasia, it is IgA is decreased. Okay, why in Wiskott-Aldrich syndrome it is IgM. So you can, I don't know if you can remember like this. So the upside down of W is M. So remember, M is decreased. Okay. So digeorge anomaly. So digeorge anomaly occurs because there is defect in the embryogenesis. So there is defect in the embryogenesis. So that time so the defect occurs in the third and the fourth pharyngeal pouch. So when the third and the fourth pharyngeal pouch is developing, so there is a defect then. So there is a micro deletion in the DNA happening. So micro deletion happens. That is why. Okay. So that is where this anomaly happens. So in these children, there is absent thymus, there is a dysmorphic faces. So these children have hypertelorism, anti-mongoloid slant, low set ears, micrognathia, short philtrum, and bifid uvula. Okay, so this is a T cell defect. Okay, and also these children present with hypocalcemic tetany, aortic arch abnormalities. Okay, so the treatment is either thymus transplant or a hematopoietic stem cell transplant. Now coming to the defects of phagocyte function. So chronic granulomatous disease. So there are various types of granulomatous disease. Uh, uh, in the chronic granulomatous disease, there is decrease in the NADPH oxidase. So 50% of the time they could be X-linked, and 50% of the time they could be autosomal recessive. Okay, so these children have recurrent serious infection. Okay, and and they have they get infected with Staphylococcus aureus, Serratia, Aspergillus. Okay, there is because of NADPH oxidase deficiency, there is impaired generation of superoxide radical. Okay, leukocyte adhesion defect. So this is very important. This is an autosomal recessive disorder. There is neutrophilia. The neutrophils have decreased defect in the adhesion motility and to phagocyte organism. So these though there is neutrophilia, they are defective. Okay, and there is a history of delayed fall of umbilicus. So this is a very important history in a child with leukocyte adhesion defect. So keep this in mind. Okay, so they might ask in a clinical scenario this can come. Okay, so keep this in mind. Delayed fall of umbilicus is a leukocyte adhesion defect. Next, coming to the autoimmune lymphoproliferative syndrome. So as in the name, as you can see, there is lymphoproliferation. So these children will present with lymphadenopathy, hypersplenism, and some children can present with hepatomegaly. So hypersplenism is so much that some children might need splenectomy. Okay, they also in their blood test there are cytopenias. Complement deficiencies, what I have told you is, so if there is the early component of the complement system, if they are deficient, that is like C1, C2, so these children are prone to recurrent bacterial infection, while the later component, that is between C5 to C9, they are prone to recurrent Neisseria infection. Okay, and patients who have C2, C4, or C1q deficiency, they are prone to develop SLE. Okay, another thing you need to remember is the C1 esterase inhibitor deficiency. So if there is C1 esterase inhibitor deficiency, they might develop hereditary angioneurotic edema. Okay, so these are the various other secondary reasons why immunodeficiency happen. Just give a look at it. Okay, you don't have to remember each and every heading, just have a look at it. These conditions cause immunodeficiency. Okay, so other immunodeficiencies, one is the, you should remember the hyper IgE syndrome. Here there is a mutation in the STAT3 gene, and these children can present with recurrent cold staphylococcal abscesses, okay, and retained primary dentition. Okay, and then there is they can have pneumonia with pneumatocysts, and this is a autosomal dominant disease, and there is raised IgE levels. Okay, so keep this in mind. So this is for today. So today we have discussed everything about immunodeficiencies. Most of the questions which are asked is all from these topics. So you have to read these topics again and again. These are very important for your NEET PG entrance point of view. If you have any doubts, please write in the comment section. I will get back to you with the answers. And also these topics are high yielding topics. Okay, so they can't even if a clinical scenario is given, you can't go wrong with the diagnosis. They will not go to a very high profile clinical scenario. They might give a direct clinical scenario, but if you don't know about these conditions, you will not be able to answer the question. So always, so please go back to the video and watch the common immunodeficiencies. Though primary immunodeficiencies are rare, these can come. Okay, so I have seen a leukocyte adhesion defect. So there are so many conditions which we get to see. So the thing is, the testing is not so much them. That is why they might be missed. But immunodeficiencies are very important for your NEET PG entrance point of view. Okay. Also, when you're subscribing to the subscription, use my code Shilpa10. Okay, and you will avail a 10% discount on the subscription. Okay, so study well. Studying daily and being motivated is very important. So in the middle of your study, so you might have started your preparation from March, so somewhere in the middle between July and August you might get demotivated, you might be tired, you might be bored of the same routine. But no, you have to hold on to yourself and study daily. That is how you can crack this entrance. And I know it's very difficult, but a year of slogging is really needed, and study well. And try to make it as interesting as possible. Discuss with your study partners, and that will, make you all interested every time. Okay, so whenever you get bored, so discuss a topic with each other. That will help you a lot. Okay, so if there is any doubts, please write in the comment section. I will get back to you with the answer. Okay, fine. Good luck.